A 35-year-old man presents with painful erythematous nodules on anterior shins, fever, and arthralgia. What is the diagnosis? A. Erysipelas. B. Erythema nodosum. C. Cellulitis. D. Vasculitis. E. Psoriasis.
The diagnosis is erythema nodosum, option B, which presents as painful, erythematous, tender nodules on the anterior shins, often accompanied by fever and arthralgia. It represents a delayed hypersensitivity reaction triggered by various conditions such as streptococcal infections, sarcoidosis, inflammatory bowel disease, tuberculosis, certain drugs, or pregnancy. Diagnosis is mainly clinical, supported by tests to identify the underlying cause, for example, ASO titers or chest X-ray. Erysipelas, option A, is a superficial bacterial skin infection caused by Streptococcus pyogenes, characterized by sharply demarcated raised borders and systemic symptoms, but not by nodular lesions. Cellulitis, option C, is a deeper bacterial infection producing diffuse redness, warmth, and swelling, usually unilateral rather than in distinct nodules. Vasculitis, option D, causes purpuric or ulcerative lesions due to vessel inflammation rather than tender nodules. And psoriasis, option E, presents with chronic, scaly silvery plaques on extensor surfaces rather than painful erythematous nodules.
A 50-year-old woman complains of floaters, flashes, and visual field defect in one eye. Fundus shows retinal detachment. What is urgent management? A. Immediate laser photocoagulation. B. Vitrectomy or scleral buccal surgery. C. Topical steroids. D. Oral antibiotics. E. Observation only.
Answer is B. The management of retinal detachment is an ophthalmologic emergency aimed at reattaching the sensory retina to the underlying retinal pigment epithelium to prevent permanent vision loss. The two main surgical options are sclerobuccal surgery, which involves indenting the wall of the eye to relieve vitreoretinal traction, and pars plana vitrectomy, which removes the vitreous gel to allow retinal reattachment. Immediate laser photocoagulation, option A, is useful in retinal tears or small localized detachments before full separation occurs, but once a true detachment is present, it is insufficient alone. Topical steroids, option C, are used for inflammatory eye conditions such as uveitis, not for mechanical detachment. Oral antibiotics, option D, have no role unless there is an associated infectious process such as endophthalmitis, which is not described here. Observation is contraindicated as retinal detachment can progress rapidly, leading to irreversible photoreceptor loss and blindness if untreated.
A 36-year-old woman has bilateral proptosis, lid lag, and chemosis. Thyroid function tests reveal hyperthyroidism. What is the diagnosis? A. Graves' orbitopathy. B. Orbital cellulitis. C. Cavernous sinus thrombosis. D. Allergic conjunctivitis. Or E. Retrobulbar hemorrhage.
The answer is A. The scenario here is classic for Graves' orbitopathy. This autoimmune condition is most commonly associated with Graves' disease, where thyroid-stimulating immunoglobulins, TSI, stimulate not only the thyroid gland, but also fibroblasts and adipocytes in the orbital tissues. This results in inflammation, edema, and deposition of glycosaminoglycans within the extraocular muscles and orbital fat, leading to proptosis, periorbital swelling, diplopia, lid lag, and exposure keratitis. Graves' orbitopathy is usually bilateral, though asymmetric involvement can occur. Lid lag and lid retraction are hallmark signs. Chemosis and conjunctival redness reflect venous congestion. Orbital cellulitis, B, presents acutely with pain, fever, and unilateral proptosis, typically secondary to sinus infection. Cavernous sinus thrombosis, C, manifests with severe pain, ophthalmoplegia, and cranial nerve involvement. Allergic conjunctivitis, D, causes itching and redness without proptosis or lid lag. And retrobulbar hemorrhage, E, is an acute, painful emergency following trauma or surgery, not a chronic bilateral process.
A 55-year-old man presents with polyuria, polydipsia, and fasting blood glucose of 220 milligrams per deciliter. HbA1c is 9.5%. He has started on metformin but develops lactic acidosis. What is the best next step? A. Switch to insulin therapy. B. Add sulfonylurea. C. Start thiazolidinedione. D. Continue metformin at lower dose. E. Begin GLP-1 receptor agonist.
Answer is A. The initial treatment with metformin is appropriate as it is first-line therapy for type 2 diabetes. However, in this case, the patient developed lactic acidosis, a rare but serious adverse effect of metformin, which mandates immediate discontinuation of the drug. The safest and most effective next step is to initiate insulin therapy. Insulin is particularly indicated in patients with markedly elevated glucose or HbA1c greater than 9%, those who are symptomatic, or those who cannot tolerate oral agents. Adding a sulfonylurea or starting a thiazolidinedione would not be suitable here, as oral hypoglycemics are less effective at this stage and may exacerbate metabolic stress. Continuing metformin at a lower dose is contraindicated after lactic acidosis. GLP-1 receptor agonists may be beneficial in some patients intolerant to metformin, especially those who are overweight. But given the severity of hyperglycemia and the prior complication, insulin remains the most appropriate immediate therapy.
A 30-year-old woman with a history of recurrent kidney stones is diagnosed with primary hyperparathyroidism. Which lab findings typically confirm this diagnosis? A. Elevated PTH, hypercalcemia, hypophosphatemia. B. Low PTH, hypercalcemia, hyperphosphatemia. C. Elevated PTH, hypocalcemia, hyperphosphatemia. D. Low PTH, hypocalcemia, hypophosphatemia. E. Normal PTH, normal calcium.
The correct answer is A. Elevated PTH, hypercalcemia, hypophosphatemia. In primary hyperparathyroidism, PHPT, excessive secretion of parathyroid hormone, PTH, most often due to a parathyroid adenoma, leads to increased bone resorption, enhanced renal calcium reabsorption, and greater intestinal calcium absorption, resulting in hypercalcemia. Simultaneously, PTH decreases phosphate reabsorption in the renal tubules, producing hypophosphatemia. Patients typically present with manifestations summarized as stones, bones, groans, and psychiatric overtones, referring to kidney stones, bone pain, gastrointestinal distress, and neuropsychiatric symptoms. Option B, low PTH, hypercalcemia, hyperphosphatemia, is seen in hypercalcemia of malignancy, where calcium elevation suppresses PTH. Option C, elevated PTH, hypocalcemia, hyperphosphatemia, corresponds to secondary hyperparathyroidism due to chronic kidney disease. Option D, low PTH, hypocalcemia, hypophosphatemia, suggests hypoparathyroidism or magnesium deficiency. And option E, normal PTH, normal calcium, represents normal physiology,